And thank you so much, everyone. Today is January 26, 2023. And today we're going to be talking to Dr. Somber about about ankle and foot orthopedic problems. So any questions that you have, start typing, use the chat, use the Q&A box, and then later on, watch the information again or share it with friends in our YouTube channel. It's called Community Chats Montefiore Nyack in YouTube. So without further ado, and in the best interest of time, let me introduce Dr. Somber, who is from the Northeastern Orthopedics and Sports Medicine, I know it's a mouthful, group that is affiliated with Nyack Hospital. And he dedicates most of his attention to all those patients with ankle and foot problems. Am I correct?
You are correct.
Okay, so Dr. Somber, what brought you to be an orthopedist and work with these type of patients?
So I always knew that I wanted to be an orthopedist. I like fixing problems. It's a very satisfying field to be able to have a problem and just be able to fix it a lot of the time. A lot of times we, can take care of something and hopefully it's never a problem for someone again. Specifically foot and ankle, it's an interesting subspecialty. It's very broad. It involves a lot of different things, and we'll touch on a few of them today. Unlike some different subspecialties in orthopedics, this one really runs between pediatrics, trauma, sports medicine, degenerative conditions. It's a really broad field. So I don't like being bored. And so this is an excellent specialty to not ever get bored with, because there's always something different. And so, some orthopedic surgeons will probably do, 5 or 10 operations, typical operations in their, career. That's what they do the vast majority of. I probably do close to 100 different operations, just because it's such a broad field. So I always thought it was kind of challenging and interesting, and there aren't that many of us. It's one of the lesser known subspecialties in orthopedics. And so there's a big demand for it. And so that's some of the reasoning why I got into this.
Yeah, and you just said it, right? And I never thought of it this way. Like most of the time when I think orthopedics, I think seniors, but foot, like an ankle, we all break a foot, or
Yep.
We're
Sure.
playing soccer. I like soccer as a Latina, so we're playing soccer, and there you go, you do to your foot or your ankle. So
this morning in the office, I saw a 1-year-old and a 93-year-old. So
a 1-year-old.
Perfect example.
Oh my gosh, I never thought of babies. Okay, yes. Okay, so looking forward to your presentation. And again, please ask questions to all of my attendees. Please ask questions. I know if you're joining us today, it's for a reason. So time to ask questions. Go ahead, Dr. Somber. You can share your screen.
Let me just share my screen here and get started. Hopefully everybody can see that.
Yes, we are seeing your screen.
Excellent. All right. So I'm going to go through. So this is a huge topic. There are so many different things that we could talk about. So I just wanted to really take, some of the highlights, some of the things that I see most commonly, some of the things that most people are probably going to experience at least one of these at some point in their life, and just talk very briefly. I mean, each topic here could be talked about for days or weeks. And so we're just going to sort of scratch the surface and give some basic overviews of what these problems actually are, and really just kind of jump from what they are and what some of the symptoms are to some simple, easy things that you could even do just on your own to just try to deal with these in terms of treatment. And then we'll talk a little bit more about just very briefly about some of the surgical treatments and other things along those lines. And so just jumping into it. So I kind of break this down into categories. These are just some big categories in terms, kind of like what I was talking about earlier about, sort of the different areas of orthopedics that foot and ankle covers. And so there is what I would sort of consider the genetic conditions, and they're not purely genetic, but these are things like flat feet, bunions, things that while they can be acquired later in life, they have a strong genetic component to them. Then there's the degenerative conditions. So it's more like arthritis, plantar fasciitis, your wear and tear conditions, if you will. Traumatic conditions, again, a huge topic. Sprains, fractures, there's so many different ones. We don't have time to even talk about it. There is what I would consider neoplastic conditions. So these are what we sort of almost more on the growths, tumors, cysts. Again, something we're not going to really touch on much today. And then there's the infectious category, which again, kind of outside the scope of today, skin, bone, soft tissue infections. These are all things dealt with in the realm of orthopedic foot and ankle care. So jumping into this, so one of the more common foot problems that a lot of people know about, but may not know a lot about it specifically, is bunions. So a bunion, a lot of people think they sort of know what a bunion is. They kind of think about it as a bump, right? So it's, hopefully you can see my little pointer here. So a lot of people think it's just sort of a bump on the side of the big toe. Turns out it's not really a bump. What it is it's actually an angular deformity of the big toe. So this is an X-ray of a typical bunion where you can see that the metatarsal bone here and the toe itself make kind of an angle here, and that angle is actually what creates that prominence on the side of the foot. So while there may be a very small amount of extra bone there, it's really an actual deformity of the toe that actually leads to that bump. There's lots of different causative factors when it comes to bunions. Narrow, pointy shoes definitely play a role. There's a strong genetic component to it. We see it a lot that they run in families. It's not that, but there is a strong genetic component to it. Feet are associated with bunions and where it creates problems for people.
Yeah. Dr. Somber, I'm sorry,
yes.
but your audio was cutting off. So would you mind repeating maybe just like the last minute?
Sure. Sorry. Can you hear me now? It's okay. Yes. All right. So the last couple points were basically that I'll start sort of have a genetic component to it. We see that quite often. They're associated with flat feet very often, and they cause, because the typical symptom that we see with bunions is people have pain, especially when they wear tight-fitting shoe wear, and that's why they create a problem. We don't really get too concerned about bunions in regards to cosmetics. That's not really a great reason to treat them. We really treat them for pain. And so in terms of treatment, so there's sort of two categories. There's basically all the very conservative treatments. These are some of the pictures you see here. So this first picture here, so this is a toe spacer. This is a silicone toe spacer. This is a bunion cushion, another silicone gel cushion to cushion the quote unquote bump.
Yeah, your video is cutting out again.
Wear modification. This is basically wearing wide toe box shoes. Uh-oh. Can you hear me now?
Yes. Now we lost you. Okay. So let's wait for Dr. Somber to reconnect. And I see we have one question already. How do you know when to see an orthopedist versus a podiatrist? And that's exactly what I had in my mind too. So we'll certainly be asking that question when he comes back. We are.
All right. Okay. Hopefully no more technical difficulties. So I'm not sure where we quite left off there, but I'll start from the beginning here. So typically for sort of early bunions, things that are less symptomatic, shoe wear modification, wide toe box shoe wear works rather well, actually. If people are willing to wear reasonable shoes, most of them really won't have significant pain from their bunions. There are splints, cushions, toe spacers, all of these devices you see here. The one that I think is the most useful is actually this toe spacer. I think that works rather well. Again, these are really not to cure bunions. They're really just to diminish symptoms. And so a silicone toe spacer can certainly work to maybe slow the progression of a bunion, but it's not going to correct it. The only way to correct it is really surgery. This picture down below is an X-ray of what I would call sort of a typical traditional bunion correction, where a bone is actually, the metatarsal bone is actually cut and is shifted over. A bit of bone is shaved down, and then the bone cut is actually pinned with some wires. This is a patient that had a hammer toe correction as well. The reason I put that X-ray there is actually to sort of compare that to what's happening more frequently now, which is something more like this. So hopefully everyone can still hear me. I just want to make sure there's no sound issues. Everything's working all right?
Everything is fine, yes.
Great, thank you. So this is kind of where bunion correction is going. So for patients who have more severe bunions, a lot of focus is being put on minimally invasive bunion correction. So this is a similar type of surgery, but done in a completely different way. So this is a surgery that's done through tiny incisions. The biggest incision done for these types of operations is less than ½ an inch. And it's done with specialized instruments that can still make bone cuts, we can still place hardware, and we can get remarkably powerful corrections of these deformities and do it in a way that requires less incisions, faster recovery, less pain, less swelling. It's really kind of the future of bunion correction. So this is an example of a patient of mine who had quite severe bunions. You can see even just the bump that's here and the quite significant deformity of the toe, both feet. And in staged fashion over the course of many months, underwent 2 separate operations for each. And these are screws that were placed across these bone cuts, and this is a typical minimally invasive bunion correction. It makes for quite an unusual looking X-ray. Someone who's not in the orthopedic field might look at this and say this looks very bizarre because it makes something of an S-curve of the bone. However, it actually is a remarkably powerful tool to correct bunions, and patients really are doing well with these. And so this is kind of where bunion correction surgery is really headed. And the really great part about these are that these surgeries are actually even most effective in sort of the most severe deformities, not just for mild ones. And so this is really where things are headed. So just touching on that, we're going to kind of bounce around a little bit. So I'm going to talk about flat feet, another very common problem. Flat feet come in sort of two varieties. There are what are considered congenital flat feet, or sort of genetic flat feet that you're born with and have your whole life, versus flat feet that you acquire later on. Hopefully you can still hear me. My internet is telling me it's a little unstable. We're still good.
It is unstable, but still, well, it's good enough.
Hopefully. I can't hear you, which probably isn't
Yeah, we
working
lost you
too
again,
well.
but now you're back. We were talking until you were saying that flat feet is a very common problem.
Got it. Okay. I'm going to turn off maybe my video. Let me see if maybe I can, let me just see if I can turn myself off here. Maybe that will help a little bit. How's that?
We hear you well.
Excellent. Okay. So, so flat feet, two types. You're born with it or you get it later in life. The severity really can vary quite a bit. Lots of people have painless flat feet that don't hurt them at all. Some people have quite significant symptoms from their flat feet. And so the pain from flat feet can be quite variable. Some people really have arch pain, where they have pain right underneath where their arch got flat. A lot of people have pain on the inner sides of their ankles when they get a form of tendonitis from their flat foot. And so one of the classic findings that you see, the way that you know you truly have a flat foot, is if you stand and you look from behind somebody, you can see that their ankle sort of leans in and their heel leans outwards. This is the classic appearance of a flat foot. And so how we treat them and what we do with flat feet varies quite a lot. So for mild flat feet that are not terribly symptomatic, observation is completely reasonable. If people don't have pain from their flat feet, there's really nothing that you have to do. The next step in patients who have more mild symptoms, especially arch pain, would just be orthotics, arch supports that they put in their shoes. These orthotics come in two varieties. They come in off-the-shelf varieties, kind of like these. They also come in custom-made varieties for patients with more significant deformity. And so that's sort of the next step up from essentially just observing it. For patients that have quite severe deformities, kind of like the picture I showed before, where they really lean in, they need something more powerful, something like a brace like this. This is sort of a custom-made ankle brace that basically is sort of an orthotic combined with an ankle support in one to really correct the deformity. And ultimately, if none of this works, then surgical correction is the last step. And so this is just an X-ray of an example of a flat foot correction. These are quite complex surgeries. They entail multiple different parts. Some parts involve moving that heel bone over. So I go back to that picture for a second where the heel bone was leaning outwards. We actually will cut the heel bone and we'll actually shift it over inwards towards the inner side to realign the foot. And so that's what this is an example of. These are two screws across a bone cut here. This is a titanium wedge through a bone cut in the midfoot to, again, create more of an arch, actually. So flat foot reconstructions are quite complex surgeries, but we always treat these conservatively with orthotics and bracing and other conservative treatment before we ever really consider surgery. So arthritis, and again, we're really just giving a brief overview of all of these topics. So arthritis in the foot and ankle can occur in numerous joints. There's 28 bones in the foot alone, and there's joints between all of them, and they can all become arthritic. But there are some that are much more common. I'm going to just touch on one, which we see often, and which often gets confused with bunions, actually. So this photo is of arthritis of the big toe joint at the base of the big toe. This bump that you see here gets confused with bunions, but the difference is that basically in arthritis, typically the bump is sort of circumferentially around the base of the toe. So you might have a bump to the inner side, but you'll also have a bump on the top. And that's from a bone spur, kind of like this right here. That's a bone spur from arthritis at the base of the big toe joint. There's narrowing of this toe joint. These can happen both from trauma. These are post-traumatic, where someone injures their big toe. They end up damaging some of the cartilage in their joint, and they can end up with arthritis down the road. It also has a strong genetic component. A lot of people just get arthritis in their big toe joints, and they get them in both of them, and they never injured them. And so we do see it from that as well. The typical symptoms: pain, swelling, stiffness, the bump like we talked about, limited motion of the toe. The biggest thing to know about arthritis is what it actually is. And so arthritis of any joint is loss of cartilage in the joint surface. So the joint surfaces are covered in cartilage, and that allows the joints to glide smoothly. And when you start losing that cartilage covering of the joints, that is arthritis by definition. It is a progressive condition. It is something that there is no actual cure for. Most of the treatment is really centered around pain relief until you get sort of to the surgical treatment options, and that's when you start talking about actual definitive cures. So in terms of treatment, just jumping into it, sort of at the baseline level, very simple, non-steroidal anti-inflammatory medications, things like ibuprofen, Motrin, naproxen, Aleve. These are sort of the first-line treatment for any arthritis, and they can be helpful when taken intermittently for more mild symptoms. Physical therapy can definitely be helpful, again, typically in more mild arthritis. The saying sort of goes that the only thing worse than an arthritic joint is a stiff arthritic joint, and so keeping motion and mobility is quite important. The next step up in the ladder is injections. These are typically what we call cortisone injections or steroid injections into the joint. These are similar treatment options for if anyone has arthritis of their knee or their hip or any other joint. These are all very typical treatment options, and they all work quite well, but they're not cures. And then you come to surgery. Surgery is the only sort of definitive way to cure arthritis. And it's really not by curing it, it's really by doing something to either replace the joint or fuse the joint. So in the foot and ankle, compared to in other joints like the knee or the hip, there's a big difference in how we treat a lot of arthritis. So big joints like the knee and the hip, they need motion. And so these are typically treated with joint replacements. In the foot, there's a lot of small joints that the motion is actually not that important. And there are no effective joint replacements for these joints. And so this X-ray down below is a typical example of a fusion of a big toe joint for arthritis. And so these are two screws that go across the joint, and basically the joint is fused. We basically trick the body into growing bone across the joint so that where there was a joint space, there is no longer. You do lose motion from this, but you also lose pain. The pain is gone. And so it's quite an effective treatment for this. It really works well. And most patients who are at the point that they need a fusion, they have such little motion in their joint already that they really don't miss the motion, and they certainly don't miss the pain. And so that's just one example. There are joint replacements for certain joints in the foot and ankle. The most common one that's coming about more and more frequently is an ankle replacement. That is becoming much more successful over time. Didn't have the greatest track record for many years, but now in the last 5 to 10 years, it really has improved significantly. And so that's a whole nother topic unto itself, but we'll move on. Plantar fasciitis. So plantar fasciitis is a very common problem. I probably see 2 or 3 patients every day in the office who have plantar fasciitis. It's the most common cause of heel pain in the world. And 1 in 4 people will get plantar fasciitis in their lifetime. And so What it is the plantar fascia is a ligament along the bottom of the foot. It attaches to the front of the heel bone. And right at that area, for a multitude of reasons, the plantar fascia ligament gets inflamed and causes pain. And so there are quite a few causative factors for it. Most people who get this have multiple different reasons that they get it, not just one. And so it's associated with flat feet. It's associated with high arches as well. Patients or people who stand for prolonged periods of time on their feet, especially on hard surfaces, tend to get this. Obesity is a factor. High impact activity and exercise like running is certainly a factor in it. And one of the biggest factors, which has only been sort of discovered in the last maybe 10 years or so, is tight calf muscles are a big contributor to this. So for most people, it just happens. They just develop pain in their heel, right in the bottom of their heel one day. The classic symptom that we hear about is what's called startup pain. So this is where first thing in the morning, you get out of bed, you step down onto the floor, and it just about takes your breath away because the bottom of your heel hurts so much. And as you get moving, it sort of loosens up, pain diminishes, and you start to feel a little bit better. And then if you stay on your feet too long, flares up and starts to get worse again. And so that's the classic symptom of plantar fasciitis. In terms of treatment, so there's lots of options for plantar fasciitis, and I generally recommend that every patient does a lot of them, does as many of these as possible all at once to really try to get it under control, because it is quite painful and it's quite debilitating for people. And if you just do one thing, it rarely will get better. And so stretching, if you had to pick just one thing, stretching is the answer. Stretching of the calf muscle, this is an excellent stretch, this wall stretch, where you straighten out your knee and you try to get your heel down on the floor and you feel a good stretch up in your calf. That's a really good stretch for plantar fasciitis. Stretching the actual plantar fascia itself is also really useful. The more stretching, the better. Deep tissue massage works really well for this as well. You don't need to get fancy with it. You can take a golf ball, put it on the floor, put your heel down right on it and roll it on it. That works very nicely for it. Orthotics, meaning foot inserts like we were talking about for flat feet, work really well for this because the plantar fascia is very, very closely associated with the arch of the foot. And so good arch support is very important. Generally, resting helps. The more steps you take in a day, the worse this gets. And so trying to minimize weight-bearing activities certainly helps. Splinting, so this is called a night splint. This device is worn while patients sleep. And the idea is basically it's just another form of stretching. It's just a way to stretch while you're sleeping. And so people get less morning pain when they stretch with a night splint. And for most people, if they do those 4 or 5 things and do it consistently, they can get their plantar fasciitis better in a matter of weeks. For rare cases where it's really severe and it just isn't improving, injections are an option. There are 2 different types of injections for plantar fasciitis. The more classic injection is a cortisone injection. I've really steered away from them for the most part. I think that they have quite a few potential complications, which I don't like. More recently, there are injections called PRP or platelet-rich plasma injections. And I'll touch on these a little bit later, which I think are more promising in regards to plantar fasciitis with less complications. Surgery is an option, although I very much try to avoid surgery for patients with plantar fasciitis. Again, surgery comes with some risk. And I think that patients who can just get this better on their own are far better off than the patients who end up needing surgery for it. And I put time there at the end just because there are some very interesting studies that show that if given enough time, even with very minimal treatment, over long periods of time, 2-year periods of time, most patients will just get better, actually, even with really minimal treatment. But 2 years is a very long time to wait. And so I would always recommend trying to treat it as aggressively as you can. So Achilles tendonitis is another really common problem. It's somewhat closely associated with plantar fasciitis. A lot of the same issues that cause plantar fasciitis also cause Achilles tendonitis. Achilles tendonitis is inflammation of the Achilles tendon. It comes in two forms. There's what we call insertional Achilles tendonitis, which an example of which is right here. So it's called insertional because where the Achilles tendon inserts on the back of the heel bone or attaches to the back of the heel bone, it gets inflamed. In quite severe cases, you'll get a bump like this, which is not really a true bump. It's actually just swelling and inflammation of the tendon itself. Some people can develop a bone spur in the back of the heel from this as well, but most of the bump is actually just from swelling and inflammation of the tendon. What is called non-insertional Achilles tendonitis is actually pictured here, which is inflammation of the tendon right behind the ankle, just in the middle of the tendon itself. You can get kind of a bump or some swelling of the tendon there as well. Both are treated very similarly. They also have similar symptoms to plantar fasciitis in that startup pain is a very classic symptom of these. A lot of patients notice that they are better when they wear a shoe with a heel, and that has to do with raising up the heel, takes a bit of pressure and tension off of the Achilles tendon, and they notice that they feel better when they wear a shoe with a little wedge or heel. So treatment options for Achilles tendonitis are somewhat similar to plantar fasciitis in that stretching is really critical. That is really the mainstay of treatment, along with rest and avoiding impact activities. But stretching of the calf, it loosens up the Achilles tendon. You have less tension on it, you get less inflammation, and the inflammation goes down. Anti-inflammatory medication, again, can certainly be useful when combined with rest and stretching. Heel lifts can be helpful. This is a typical heel lift where you just put a little wedge in your shoe underneath, which just raises up the heel. That's a temporary fix, but it can certainly give some relief. Mentioned briefly earlier about plantar fasciitis, about PRP injections. Cortisone injections are completely contraindicated around the Achilles tendon. There's very good evidence that there's a high risk of damage or rupture to the tendon when a cortisone injection is placed around the Achilles tendon. So we don't do that. But these PRP or platelet-rich plasma injections can be quite useful in really recalcitrant cases. And so the procedure for platelet-rich plasma, which can be used for other conditions as well in orthopedics, is essentially where we draw blood from a vein in the patient's arm. We centrifuge their blood in a centrifuge in the office, and we spin it down and we collect a very small amount of it that is plasma with concentrated platelets in it. And the reason that we do this is that platelet-rich plasma has been shown to have a lot of beneficial effects in regards to healing, especially of tendons and ligaments. The way that it works is quite different than cortisone. It actually is a highly inflammatory substance, and what it does is it creates a big inflammatory response from the body, and inflammation is actually it's a good thing, actually, because inflammation is the body's healing response. And so for Achilles tendonitis or plantar fasciitis, when you inject PRP, you get quite a bit of inflammation. It's quite uncomfortable, actually, for a period of time, but it really triggers the body to heal these ligaments and tendons. And it has some good evidence behind it. If all of these things don't work, there are surgeries for Achilles tendonitis. This is sort of a cartoon example of a typical Achilles tendon operation for tendonitis. This is where we basically can split open the tendon. We can basically debride away any damaged tendon fibers. We can take any bone spurs off of the back of the heel, and then we repair the tendon with a construct like this. This is some sutures, which are anchored into the bone with some bone anchors, and then the tendon is repaired. And so these work quite nicely, but these are, relatively longer recoveries, and the vast majority of patients can certainly get better without surgery. And so that was a very whirlwind overview of orthopedic foot and ankle problems. Sort of the summary is stretching is good for many, many orthopedic foot and ankle problems. And so if I could give one take-home message, it would be stretch a lot, especially your calf. It is good for almost everything. Wearing good arch support is always a good idea. Proper fitting shoe wear. So a lot of foot and ankle problems come from just poor fitting shoe wear, poorly supportive shoe wear. And so that is a big emphasis on that. And again, and this sort of covers almost all of lower extremity orthopedics, but low impact exercise is definitely better. All the high impact exercise, running, jumping, anything like that puts a lot more wear and tear, especially on the joints in the foot and ankle. And so if all these things that we discussed, some of the simple stretches and basic treatments don't really work, then it's time to see an orthopedic foot and ankle specialist.
Thank you so much, Dr. Langston. And I love the last picture. I wish you could see my face, because when you were showing all those surgeries, I was like, ew, and now I see this and I'm like, finally a picture for me. So thank you so much for all the information. And
No
we
problem.
do have some questions.
Sure.
So let's start with the questions. How do you know when to see an orthopedist versus a podiatrist?
I'm so glad that somebody asked that question. So this is a topic near and dear to my heart. So there is a lot of confusion out there because I would say the sort of common feeling amongst many patients is that foot problems are seen by foot doctors and foot doctors are podiatrists. And there's a significant difference between podiatrists and orthopedic foot and ankle surgeons. We're trained very differently. The orthopedic training is, we do 4 years of medical school, we do 5 years of orthopedic training, we do a separate year of orthopedic foot and ankle fellowship training. And so it's a very, very rigorous training. And so it's a whole different specialty, basically. And so there is some overlap for sure. We do treat some of the same conditions. Obviously, my perspective is from that of an orthopedist. And so, I think that especially when it comes to certainly, and these are things we didn't really touch on, but when it comes to things like traumatic injuries, fractures, tendon tears, things of that nature, I think those fall certainly more into the orthopedic category than the podiatry category. Again, doesn't mean there aren't podiatrists who are treating these types of problems. I think that, when it comes to things like, say, bunions and hammer toes and these types of issues, plantar fasciitis, they are treated by both. I don't think that there's a huge discrepancy in how we treat those things. I think surgically there are some differences just in terms of techniques and just how we're trained. And then I think there's sort of the other side of things, which are the things that almost only podiatrists treat, that orthopedic foot and ankle surgeons don't treat. And that would be things, skin problems, foot wounds, diabetic foot problems, toenail problems. These types of problems are almost exclusively the realm of podiatrists. And so I think there's a lot of confusion out there, actually. And so I think that's a great question. I think in terms of bone, joint, muscle, and tendon problems, yeah, I mean, I'm obviously a little bit biased, but I think that those are definitely the time to see an orthopedic foot and ankle specialist. And many orthopedists, not just foot and ankle specialists, but a lot of orthopedists will treat a lot of these conditions And if they think it's something that really needs to see a specialist like me, then they will refer them to me.
So skin and nails, podiatrist, and you gave us the list, the tendons, the bones.
Yeah, I think really anything other than, sort of dermatologic, sort of skin conditions, nail conditions, foot infections. That's another one that I think is probably much more commonly treated by podiatrists. Other than that, I think orthopedic foot and ankle specialists cover pretty much everything else.
Yeah, that's a great differentiation to make, especially, because we often don't know where to go. So
Correct.
thank you very much for that clarification.
Sure.
We have another question. I have bunions and plantar fasciitis, and bunions run in my family. My mother and sisters all have them. Only my mother has had surgery and her feet look horrible, so I do not want to go through it. What are your thoughts?
So I think I hear this all the time, that I think bunion surgery has gotten a very bad reputation. I get many patients who come in who I've never seen before, and the topic of bunion surgery comes up, and everybody says, I probably hear this from 90% of patients who say, oh, I heard it's just a terribly painful surgery. It really hurts. And I think it's really a misconception. I think that especially with the more minimally invasive surgeries that we're doing now, I have many patients who are almost disappointed in how little pain they have. They are shocked at how little pain they have afterwards. It's not to say that it's an easy surgery to go through, and there's certainly some recovery time, but I think it gets a very bad reputation in regards to pain, and I don't think it's really warranted. I think that, the decision of whether or not someone should have surgery for their bunion is a more complicated topic. And I think it's really related to two things. One, I sort of talked about, which was, it really comes down to pain. If people have painless bunions that don't hurt them and really don't limit them in terms of shoe wear and activity, there's very little reason to have surgery on them. The only other factor that really comes in is progression. So there are people who have relatively mild bunions, and over the course of a few years, their bunions really progress. Their toes really move over towards their second toes. They notice a significant difference over time. And so if someone is having a rapidly progressing bunion that really seems to be worsening quickly, you don't want to let it get to a point that it's quite severe, because the surgeries can become more complex if the deformity is more severe. And so that is a bit of a looser indication for surgery, but it is a relevant one. But short of that, if it's just, I don't like the way my foot looks, I would always recommend against it, because if you have a painless foot that, just has a bunion and you don't like the way it looks, it's highly unlikely you're going to be happier after surgery. And so we always try to sort of talk people out of that if they're really not having significant symptoms.
And you were showing those devices to put in between fingers, I think in your second slide or something. I was already checking them on Amazon. They're not even expensive. So
right.
I think, because
yeah, those are great options. I mean, I think for someone who's trying to avoid an operation, who maybe has some symptoms, that is an excellent way to prevent progression. It's not, there are some really misleading things out there about before and after pictures, and people who use some sort of splint or little spacer, and all of a sudden their bunion is gone. That is unrealistic. That really doesn't happen. This won't correct it, but it really can help with symptoms, and it can absolutely slow the progression of a bunion, which is really quite important.
Is there an age range where you should have surgery? I'm actually thinking of my mom. My mom is 79 years old. She has terrible, painful bunions. She has a hard time, finding shoes that don't hurt. Is it too old to have surgery?
So there's really no age cutoff. I think it depends. I actually find that, and this is very anecdotal, this is not with any real evidence, but I find that there's a lot of patients in their 70s, 80s, 90s who have quite severe bunions, but they actually manage them rather well. They just don't have very severe symptoms. And so we obviously try to avoid surgery at that age. But no, there's really no, if someone has significant symptoms and they're really struggling with it, there's absolutely no reason that you can't have surgery at, in your 70s for bunion correction. It used to be a bigger issue. If you remember that slide that I showed, I'll go back to it actually. So if you look at this, so this is sort of what we used to do. And some people still do this, but the problem is that that's just a little tiny wire holding a bone. And in patients who are in their 70s or 80s, they may have some osteoporosis. Their bones may be kind of thin. That's not very secure fixation. And the difference between that and this, where you're really putting some significant hardware, which may scare people away a little bit. And I know that looks, pretty aggressive, but at the same time, these types of screws and things that we have now to work with are so good with even relatively poor bone quality. And so there really is no reason that people, even with osteoporosis, can't have this type of operation.
Great to know. So here's another question. My husband broke his ankle over a year ago, and he still has numbness in the bottom of his injured foot. What can he do to alleviate the numbness?
So that's going to be a difficult one, just because there's obviously a lot of detail there and a lot of things that I probably don't know about that specific case. That being said, numbness, generally speaking, is almost always some type of nerve problem. And so when I hear numbness, especially in the bottom of the foot, it's likely from some type of nerve injury. It depends on the specific situation for sure, but it's likely not directly due to just a broken ankle. Patients can injure nerves when they, at the same time that they injure an ankle. If they break their ankle and they twist their ankle hard enough, you can certainly stretch a nerve and get some numbness. That's a very specific sort of example. And so it's difficult to say exactly how I would work that up. It's something that certainly could be looked into. There is nerve testing. If someone has numbness, a lot of times we will have a neurologist or a specialist do what's called an EMG, which is a nerve test to test the function of patients' nerves in their leg and foot. And so that is a reasonable option if someone's having persistent numbness. But that's one where I would need to know a lot more detail and be able to examine that patient and know the exact history to kind of have a better idea of exactly what the reasoning is.
Another one. Good afternoon. I have plantar fasciitis in one foot and Achilles tendonitis in the other. I have changed my sneakers to one with greater support for my flat feet. Had a steroid injection once, use a night splint and do stretches, still with pain. I am currently under the care of a podiatrist. Any suggestions for some relief without an anti-inflammatory? Oh, I think we lost Dr. Somber again. So let's wait a little bit, but these are all great questions. So we have, hopefully you
Sorry
guys.
about that.
Oh, there you are. Okay.
I lost you, but I'm back.
Okay, perfect. Should I repeat the question for you?
Yes, please. I heard just the very beginning.
Okay, so good afternoon. I have plantar fasciitis in one foot and Achilles tendonitis in the other. I have changed two sneakers to one with greater support for my flat feet, an steroid injection once, a night splint, and do stretches. Still, I'm in pain, and I'm currently under the care of a podiatrist. Any suggestions for some relief for the pain without an anti-inflammatory?
Yeah, so I mean, we do see this from time to time where, especially for the plantar fasciitis, patients can have some persistent symptoms. I tell every patient that this can be a pretty prolonged course. This can take a long time to get better. Plantar fasciitis does not go away very quickly in some cases. Patients have to be pretty patient with it, and it's hard because it's just, it's frustrating and it lasts a long time. And so, it can take several months for it to go away. And that's with really good stretching every day, really working on it. If someone's done all of those very reasonable things and is still really having significant symptoms, the next step for me in regards to plantar fasciitis would likely be a PRP injection, like I talked about. I do not really like the idea of repeated cortisone injections. I think that can create a lot of issues. The things that I worry about with that are injecting cortisone around the bottom of the heel area there. One, you can actually damage the plantar fascia itself, the ligament. There is a known risk of rupturing that ligament after injection. And also, there is, if you were to feel the bottom of your heel, you'll notice that there's quite thick soft tissue on the bottom of your heel. There's what's called the plantar fat pad, which is basically all the cushion between your skin and your heel bone, because when you walk, if you were walking right on your heel bone, it would be very uncomfortable. And repeated injections of cortisone to the bottom of the heel can actually dissolve that fat pad in the bottom of your heel, and you can end up with a very soft heel, and it can be a really difficult problem to deal with. And so I really try to avoid repeated cortisone injections. I think a PRP injection, while certainly a bit involved, has much less risk of those types of problems. In fact, it really doesn't have the risk of those problems. And so I think it can work as well, if not better, than a cortisone injection. And I think it has less risk. And so I think that's a good option.
And Dr. Somber, are these PRP injections something that this person can ask the podiatrist for, or does she or he need to go to an orthopedist?
So as far as I know, there are probably some podiatrists that are doing it. I think it's more commonly used by orthopedists, but it can be done by both. Full disclosure, just the only real downside of a PRP injection is that PRP injections are not covered by most insurance. And that's the only reason why it is not used extremely widely. And so that is just something that patients need to know. It's just, we wish it was, and it is just not, for reasons no one really understands. There's some good evidence behind it, but and so there is a cost associated with it for sure. But I think the results speak for themselves. I think it really does work well for many people.
On a sneak peek, how much is an injection? Any idea? Like, is it very costly, or?
It is. They are not because it involves kind of a pretty high tech machine that has to actually separate out this platelet-rich plasma. There's quite a bit involved in it, and so there's some fixed costs to it that are just unavoidable, unfortunately. And so there's a range, but I would say they probably do range somewhere roughly, say, between $700 and $1,000. They're not cheap. It is a big expense for sure. And believe me, these are not for just anybody who has plantar fasciitis. I would never suggest it as a first-line treatment or even a second-line treatment. But for the patient who's really struggling and really having a hard time, I think it is a good option.
And this is an injection that you get once and you're supposed to be well for a long time, or is it something
Correct.
that you have to
do? No, this is something, right. It's meant to be a one-time injection. I would say on rare occasion, I've done them twice, but for the most part, it's once. And yeah, the goal is to cure it. It's not a Band-Aid. It's not, something that is, just covering it up. And so, yeah, no, it is meant as a cure. And again, nothing is 100%, and nor is this, but it is not meant to just be a temporary thing.
So if you calculate, if you're going to have surgery or something like that, you're going to have to pay your copay and your hospital stay and all of that. So actually, if you can, have less side effects, lower recovery and all of that, and pay about less than the surgery, I don't think it's that costly after all, even if it's not covered by insurance. So something to think about, if you're comparing cost between surgery and the injection, right?
100%. And I will tell you that the patients who are really struggling, they basically are at a point where they will do anything to
Yeah.
get it better. I mean, people feel pretty bad with it and they get really frustrated. And so, I mean, that is the one procedure that I even do that is not covered by insurance. It is a rare thing, and I don't do it that frequently because I don't need to. But that is the one downside of it. But I agree with you. I think for the right patient, I think it is a reasonable trade-off.
Yeah. And we're running out of time, definitely, but we have two quick questions, if you don't mind staying with us for another 3 minutes. So
Sure.
one is, can you discuss why bunion surgery is recommended for pain, but not for cosmetic reasons?
Sure. So it's a good question. So there have been numerous studies done on this. And the interesting part is that there are what I will call side effects to bunion surgery. And what I mean by that is that when you are cutting bones, when you are shifting bones over, when you are putting hardware in, there are things that come of this, meaning you can have some swelling around the base of your big toe. You can have some stiffness of your big toe. There are, I mean, I kind of joke with patients and call it collateral damage. It's not unexpected. These are typical expected sort of things that come along with bunion surgery. And what I find, and what a lot of studies have found, is that if you take a patient who has a painless bunion and you operate on them, there's only one direction you can go. You can only get worse, basically. You can't feel better than having no pain. And so what they have found in many studies on this, and I mean, I actually have no personal experience with it because I just don't do cosmetic bunion surgery, but what they have found is that the satisfaction rate among patients who have bunions done who did not have pain prior is very low. And it's because they have some of this swelling or stiffness and they feel worse than when they started. Even though their foot may look cosmetically better, their function is worse. Now, if you compare that to somebody who had pretty significant pain every day of their life from their bunion and they can't wear shoes and they can't do anything they want to do because it's hurting them all the time, I will tell you that the vast majority of patients who have bunion surgery with me, they don't even notice a little swelling or a little stiffness. They feel so much better because their pain is so much less than what they had before, that those sort of side effects are so minimal that they don't care. They don't even notice it. And so the difference is that when you start with someone with pretty significant pain, you have a lot of room for improvement. When you start with someone who has no pain, you have no room for improvement. And so that's really the long-winded explanation.
Yeah, that makes sense. Now your feet might look prettier, but they are in a lot of pain. So
right.
Okay. And very quick, the last one. What does the typical recovery time is for surgery? I guess is bunion.
So it does vary, but I will tell you that, the bunion surgery that I showed, that minimally invasive bunion surgery with those screws, that is such rigid fixation that we can to bear weight on their foot after just 2 weeks. And so traditionally, it was about 6 weeks of weight bearing on the patient's heel where they really could only walk on their heel and they really couldn't put weight on the front of their foot. Now we let patients weight bear at 2 weeks. And so by no means is someone recovered in 2 weeks. Patients have swelling and some stiffness and soreness for probably a month or two. That's not unusual at all. And they're not into probably completely regular shoe wear for probably somewhere in the 6 to 8 week range. But that's really the number. To be 100% recovered, really as good as you're going to get, is longer than that for sure. But that's really just to let some residual swelling go down. But now, we can be much more aggressive in terms of weight bearing and walking earlier with these new techniques.
Well, thank you so much, Dr. Somber. You were very generous with your information, letting us know about all these common problems. This was really great. And thank you to our participants for all the very great questions that we had today. And Dr. Somber, in case anyone wants to reach you or your practice, is there any contact information you want to share with us?
Sure. So, and I apologize in advance for all the internet issues. I wish that I could have my camera on and not have been cut off several times. So apologies there. In terms of getting in touch with me, so I am part of Northeast Orthopedics and Sports Medicine. So we have a website. It's an acronym for Northeast Orthopedics Sports Medicine. So it's NEOSM team, TEAM.com. So that's an excellent way to find us. My office number is also, I can give it to you. My office phone number is 845-358-1000.
845-358-1000. Yes.
Ooh, did I lose you there for a second? There, it's
845-358-1000.
correct, exactly.
Got it. Okay, I put it in the chat, and it's neosteam, neosteam.com.
Yeah,
Okay.
NEOSM team.com, exactly.
Excellent. Okay, well, thank you so much. It's been a pleasure spending the last hour with you, Dr. Somber, and thank you to all of our participants today. I will see you next week. We're going to be talking about how technology via computers and all these new apps that we have are helping us get in touch with our doctors, make appointments, contact them, ask questions. So if you want to learn more about how you can use your computer to get closer to your doctor, join us next week, 12 o'clock. Same thing, community chats. Thank you very much. Bye-bye.